Amgen is committed to advancing science and developing treatments for patients with serious and rare diseases. Rare diseases demand urgent attention and are a core part of Amgen's mission to serve patients. To learn more about Amgen's rare disease resources, visit www.rareiscommunity.com.
Welcome to the Pupil Pod, where we use clinical cases to guide discussions on board review topics. I'm your host, Sila Bal, and my guest today is Dr. Rachel Simpson. Dr. Simpson is a cataract and glaucoma surgeon, the residency program director, and the vice chair of education at the Moran Eye Center. Dr. Simpson, thank you for joining me tonight.
Hi, Sila. I'm so happy to be here with you. It really is. I've been looking forward to this for quite a while.
I have too, and I know that you're super busy, but thank you for joining us. So we will jump right into the case. This is a 56-year-old woman who presents to you from her optometrist for eye pressure. She knows that she had not had an eye exam in 10 years and recently went to renew her glasses prescription. Otherwise, she remains asymptomatic. On examination, best corrected visual acuity is 20/20 in both eyes. She has no RAPD, and her IOP is 26 and 29. Dilated exam reveals inferior and superior disc thinning with an estimated cup to disc ratio of 0.6 in the right eye and 0.7 in the left eye. Now, Dr. Simpson, how would you proceed at this point with working up the patient? Are there any specific questions that you would ask or any tests that you would want to order right off the bat?
Yeah, I think, obviously the first thing I like to do is just kind of get a sense of what my patient's history is. So I'd sit her down and ask the regular screening questions that we ask for all of our, new glaucoma evals, family history of glaucoma. If so, then I usually ask, who was it? How many people in your family had glaucoma? How was it managed? How many drops were they on? Did they ever need surgery? Did anybody go blind from glaucoma? Because those can all kind of clue you in on just how strong this family history, if they have one, really is. And then I'll do take a look at their refraction, take a look at their glasses if I don't have access to refraction, because obviously both hyperopia and myopia put patients at risk for different types of glaucoma. So it's something I always want to know. And then, especially with that increased IOP, I really want to know what her pachymetry is, what her central corneal thickness is, because that really helps frame my idea of what is a normal pressure for this patient and what is abnormal for this patient. So I would start there, and then of course all of our new glaucoma patients have to get RNFL OCT. That's kind of a mandatory thing these days. And then all of our glaucoma patients also get usually a Humphrey visual field. And I want to put a quick plug in when we're ordering visual fields. The standard that used to be everyone ordered, well, way back in the day was a 30-2. We don't do that anymore. Please don't do that anymore. Those tests are unreliable, and the artifact that you get, especially peripherally, is really hard to differentiate from true glaucoma. So of course we moved more to a 24-2, which is great, but it's really much more sensitive for patients you've already established that they have optic nerve damage. A 10-2 patient in a new glaucoma eval is actually going to give you a lot more information than just a 24-2. So I have access to a CETA faster testing algorithm now, which will do a 24-2 with a superimposed 10-2 on top of it, which is really nice. But if you don't have access to that, I always recommend for the first visual field, you do a 24-2 and a 10-2, which is a lot of testing, but it's absolutely worth it.
Wow, that's so interesting. I actually don't routinely do that, but I'm definitely going to look into what I have access to in my new practice. And not that I'm managing glaucoma primarily, but as a cataract surgeon, you see these patients sometimes. It's nice to get that testing. So I will definitely make sure I do that. Um,
Absolutely. I'm going to put one other plug in for a 10-2, especially for comprehensive doctors and cataract surgeons, because you'll do surgery on these patients and maybe they'll have mild glaucoma or they'll have normal tension glaucoma that we didn't really detect. And after surgery, they'll tell you about a visual field defect that is kind of in their central vision that doesn't show up on a 24-2. And then when you do a 10-2, it shows up. And if we didn't know about it ahead of time, then they'll think you gave it to them. So a 10-2 really does give you invaluable information about really small but really impactful visual field defects in these patients.
That's a great pearl that I'm definitely going to incorporate into my own practice. So, just like you suggested, we performed visual field testing for this patient. It's a hypothetical patient, so, it's a 24-2, but it could be anything. The patient had a high quality and reliable test. There were no noticeable visual field defects. However, the OCT RNFL showed inferior and superior thinning. Now, the reason that we're highlighting this is, would you say that a single test, especially like this, is enough to make a diagnosis of open angle glaucoma? Is there anything else that you would want to know? Would you diagnose this patient? How would you manage her?
It's a great question about these kind of, and I always have this conversation with my patients. What I have right now is a snapshot in time, and glaucoma really is a disease of progression. And so it's really difficult to say whether or not this is glaucoma if you're just looking at a snapshot. Certainly, thinning, especially inferior and superior thinning on an RNFL OCT, is pretty characteristic of the type of thinning we would expect to see in someone with glaucoma. And so this is where I would kind of use the other context clues. If her packies were really thick, I might be more inclined to say, you know, give me some more information before we decide if this is glaucoma. But if her packies were really thin and she had a really strong family history, then I might be more inclined to say, hey, we still don't know 100%, but let's err on the side of treatment. So that's really where I let all of the other exam findings and the patient history guide my next steps. But I do always tell the residents that a snapshot is just a snapshot, and you can't really understand the patient's disease unless you have multiple testing. So, particularly in the beginning, especially if there's visual field defects, I always recommend repeat testing, usually about 6 to 8 weeks later, just to kind of establish a baseline, and make sure that what we're seeing is, in fact, what we're seeing.
So, would you start this patient? Let's say she had thin packies. Would you start her on drops? And if so, what's your go to starting drop? What's your goal IOP? How would you get started with this patient?
Yeah, in this patient, if we're saying, if her corneal thickness was somewhere around 500, especially if she was like, oh, a grandma had glaucoma, or one of my parents had glaucoma. So you've got thin packies, you've got a positive family history, you've got elevated IOP, and you've got thinning on OCT. For me, that's enough at this point in time to definitely start her on medication. And generally speaking, I'll have a conversation with the patient about the different options that are out there. I will oftentimes offer SLT as a first line treatment, but this podcast that's focusing on glaucoma medications. So, and oftentimes I'll find patients, we talk about SLT and they're just more comfortable starting drops. So we oftentimes still go down the road of starting medication as our first line. And like most people, I tend to prescribe a prostaglandin analog as my first line treatment. So I often choose a prostaglandin analog as our first line treatment. And the reasons for that are multiple. One, it really is just the most effective IOP lowering medication available. It is generally speaking about 5 to 10% more impactful than timolol. And the other thing I really like about it is that it's dosed once a day. We know our patients are really bad about remembering to take their eye drops. So if I can make things as simple for them as possible, I like to do that. So a one time a day dosing is really the best case scenario for patient compliance. The other thing I really like about the prostaglandin analogs is that while they tend to have superficial cosmetic side effects, they don't have a lot of systemic side effects. So you don't have to worry about some of the big things like bradycardia and hypotension that you see, say, with a beta blocker in these prostaglandin analogs. We do see, as everyone knows, the hypertrichiasis, the periorbital fat atrophy, the risk of iris pigmentation changes. So those are all things I do discuss with my patients beforehand, especially if they have the hazel or the yellow according to the BCSC irises. Then I'll make sure to have that conversation. And then I always screen them for any history of CME or herpes keratitis, because prostaglandin analogs can reactivate HSV keratitis in these patients. So I want to make sure they don't have anything like that in their history.
So, what if your patient needed a second drop? What's your next line of therapy, and what's the next class of drops that you would kind of think about?
So I'll often move on if we need more medication. I'll often move on then to the beta blockers. And again, the reasoning there is they're just the second most impactful drop that we have. So prostaglandin analogs come first, and then beta blockers come second. Um, and the other nice thing about beta blockers is it is oftentimes very appropriate to start with a once a day dose. So I'll tell patients, okay, you're using your latanoprost in the evening. I want you to start using timolol once a day in the morning. And so they're still getting two medications, but they're only using drops twice a day, and it's just one drop each time. So again, with compliance, that makes things a little bit easier. I do remind them with timolol, we know that the mechanism of action makes it much more impactful in the morning versus the afternoon or evening. So I really stress with them, it's important you get that morning dose of timolol in the eye every morning, kind of first thing when you wake up, to get its maximum impact. And that does remind me, with prostaglandin analogs, people often think that because it's dosed at night, it's a similar situation to timolol, where it's more effective if we're using it at night. And that's not the case. One of the side effects of prostaglandin analogs is conjunctival hyperemia. And the drug companies were really smart, and they figured out that if we tell people to use it at night right before they go to bed and they close their eyes, then a lot of that redness will go away by the time they wake up the next day. So it is only for cosmesis that we tell patients to use prostaglandin analogs at night. So I'll oftentimes tell them, if you're struggling to remember to use your evening drop, if you're falling asleep before you can get it in, you can use it at any time of day as long as it's the same time each day. For the timolol, that's not true. I really reinforce with them, you have to use it in the morning.
I didn't know that about the prostaglandin analog, so that's such a good tidbit to know. Just circling back to the beta blockers, what are some of the questions? I think you alluded to them, but the important questions that you ask patients before starting the beta blockers?
Yeah, so I think a lot of people are really familiar with the big side effects for the beta blockers, your heart block, your bronchospasm. So I'm always asking these patients, hey, do you have any problems with your heart? How's your blood pressure? How's your heart rate? Do you have a pacemaker? Do you have a cardiologist? And sometimes patients won't answer yes to any of those, but then they'll be like, oh, yes, my cardiologist. And then you'll have to go down that road of figuring out what they're seeing their cardiologist for. And then always ask them about any problems breathing, history of asthma, history of COPD, because as we know, there is that cross reactivity with the beta blocker receptors in the lungs. And then one thing that wasn't quite as a well-known, even when I was in residency, but has really come to the forefront, especially in the last couple of years with an increased awareness of mental health, is that it can have some significant effects on our mental health. So patients with history of severe depression, severe mood swings, those are things I warn them about. Just, hey, sometimes this medication can impact your mood. And so if you notice that you're feeling more down lately since starting this medication, that is something that you should let me know. And oftentimes I think we tend to minimize the impacts of this medication, but I'll say I had a patient who was scheduled to go in for a pacemaker literally the next day, whose heart rate was consistently in the 40s, and he just happened to tell me about it. And I said, stop, let's stop your timolol, tell your cardiologist you want to wait 2 weeks and then check your heart rate again. And his heart rate was consistently in the 60s ever since then. So he got to bypass a pacemaker just from stopping his timolol. So the effects really can be quite real and quite serious.
I think that's so important. Like sometimes we think, oh, I'm just giving them eye drops, but especially in older patients, the systemic absorption of some of these medications can be so significant. And we really like to joke that we're just focusing on that portion of the face that we care about most, but we are taking care of the entire patient. It's really important to remember that. Okay.
Right.
So,
We're doctors first and
yeah,
eye doctors second. Exactly.
exactly. I know being married to an ER doctor, sometimes I'm like, am I a doctor?
We're
We
pretend.
absolutely are. We absolutely are. Okay, so moving on to the next class of drops, alpha agonists. Can you tell us a little bit more about those?
Yeah, so the alpha agonists tend to be kind of my third line. It's obviously nice because they'll come in those combination formulas as well, which I'm sure we'll talk about. But the alpha agonists, they work great. They require a little bit more frequent dosing. So technically, for its most impact, you really should be dosing it 3 times a day. It gets a little bit challenging for patients to use drops consistently 3 times a day, and the alpha agonists are just a little bit less powerful than the first two medications that we talked about. The other thing that's really classic with these medications is the impact on the ocular surface. So your bromonidine and your aproclonidine are really notorious for that ocular surface, follicular conjunctivitis, conjunctival hyperemia. You can get the periorbital dermatitis around the eyes, and when you see it, it is unmissable. These patients who have the alpha agonist allergy or reaction, their whole orbits are just glowing red, and it looks so uncomfortable. It's pretty classic when we see this.
Yes, I feel like anyone in training can attest to how bad this looks when the patients come in. When you first see it, you're like, this has to be something else, but
Yeah,
it's really just it's
it's really just the bromonidine.
exactly. Okay, so then our final of the big classes, and then we'll get into some of the newer and maybe less known classes, the carbonic anhydrase inhibitors.
Yes. So, of course, in this category, we have our topical medications, and we also have the oral medications, the acetazolamide and the methazolamide. But classically, what we see here is the dorzolamide or brinzolamide. And again, they kind of come as our last line or our last option because dosed twice a day, actually can be dosed up to 4 times a day. And you just don't have quite as much bang for your buck with these as you do with really any of the other medications. The prostaglandin analogs are somewhere between 25 to 32% ish. Timolol somewhere between 20 to 30. The alpha agonists, again, somewhere between 20 to 30. The carbonic anhydrase, they're really more like 15 to 20. So you're kind of running out of options when you start to add the carbonic anhydrase inhibitors. And these are another one that are pretty notorious for just causing a lot of problems with ocular surface. It can cause a lot of irritation, similar to bromonidine, usually not quite as severe. And then you have the oral version of these medications, which is kind of our big gun that we use whenever we need to emergently get the pressure down. And when we give Diamox, I have to warn patients extensively about the side effects. Diamox would be the perfect medication I mean, it works almost always in everybody, but the reason why we can't use it long term is just the massive amount of side effects. So I always warn people about the numbness and tingling of the hands and feet because I've had patients who thought they were having a stroke because they were taking Diamox. I always warn them that it is a diuretic, so don't get up too fast. Oftentimes these are patients who are a little bit older, and so they're already prone to falls. And then if we're diuresing them and not warning them about that, they are at significant risk for falls. And then the big one that everybody hates is the alteration of carbonated beverages, and it gives them a metallic taste. And then it can cause, pretty massive electrolyte abnormalities if you're having someone on this for long-term renal stones. It's not a benign medication, and so that is why it's really only used in emergent situations and not for long-term glaucoma management.
So, speaking of non benign and urgent situations, what are some of the other medication classes? Maybe some of the ones that we do use versus ones we don't use, and then some of the newer ones?
So there are a number of less frequently used glaucoma medications. We were talking about Diamox as kind of our big gun. The other big gun that we have is mannitol, which is only given IV, I think, at this point. And that's something, full disclosure, I've never actually used in my career. Even when we're doing cataract surgery on someone with elevated pressures, angle closure, it's just not something that I traditionally use, but you can use it in an emergent situation to get the pressure down. It really does work well. There are some significant side effects, including a lot of electrolyte abnormalities, and you can cause cerebral edema with it. So, again, not a benign intervention at all. And I think one thing that I have learned is that there are much better ways to manage acute IOP spikes other than mannitol. And even perioperatively, it's very rare, if ever, that you would actually need to use mannitol in an urgent situation. And oftentimes not worth the risk. And then we have our real old school glaucoma medication, pilocarpine, which again works fantastically well. It really does lower the pressure. The problems with pilocarpine, and the reason why it's really kind of fallen out of favor, is the dosing schedule is not friendly at all, 2 to 4 times a day. And the side effect profile is really not friendly. Patients get a pretty significant eyebrow ache. It feels like that ice cream headache all the time for weeks. That's not particularly how I want to spend my day each day. And then there's risk of retinal tears, retinal detachment. Interestingly, we've seen kind of a resurgence of the pilocarpine in our anti-presbyopic drops. So I'll have my glaucoma patients ask me, like, what is this new medication? Is it safe? And I was like, this is actually the oldest medication that we have, and now it's just in a more dilute formula, so hopefully less side effects. But yeah, that original pilocarpine was pretty uncomfortable for patients.
And then what about our newer class? It was starting to be used in some patients when I was kind of finishing up residency. Do you ever use rho kinase inhibitors?
Yeah, rho kinase inhibitors, also same for me, kind of came out as I was finishing residency. And I remember pretty distinctly suddenly having this new tool available in some of our glaucoma patients where we were talking about trabeculectomy, and we're like, hey, let's try the rho kinase inhibitor on you and see what happens. And I would say, 50% of the time we were able to get the pressure down and save them from a surgery, at least initially. The problem with the rho kinase inhibitors, like a lot of the glaucoma medications, is tolerability over the long term. And a lot of these patients have really, really significant conjunctival hyperemia. That's by far the most common thing that you'll see. Interestingly, you'll also see corneal verticillata with the rho kinase inhibitors. But it is nice in that, unlike a lot of the aqueous suppressants that are all kind of working on the same pathway, we're all shutting down the production of aqueous using different mechanisms, or the prostaglandin analog, which is uveoscleral. This gives us a completely novel and previously untapped resource for lowering eye pressure. So now you have something that's working at the level of the trabecular meshwork in your rho kinase inhibitors. You have your aqueous suppressants, and you also have your uveoscleral outflow in the prostaglandin analogs. So you're hitting the IOP in 3 different places, and I think that's kind of nice to be able to have that to add into your treatment algorithm.
So, speaking of having the different mechanisms of action and really targeting the effects, when I know that there are a million combo drops, and especially when I have a patient that gets their drops overseas and then comes to us, I'm like, oh, I hadn't heard of this one. But what are some of the commonly used combo drops that you like to use in your clinic, and what kind of patients are they the most ideal for?
So I love a combination drop. I think anything that makes a treatment regimen for patients easier and requires overall less drops over time is going to be more sustainable for them. I also try and think about preservative load with each drop. So if I have someone on a prostaglandin analog, a beta blocker, a alpha an alpha blocker, and a carbonic anhydrase inhibitor, and they're using those as directed. So that's 1, 2, 3, 4, 5, 6, at least 6 doses of preservative over the course of just a regular day, plus artificial tears. We're already getting way too much preservative in the eye. So I think about it a couple different ways: ease of use, how easy am I making their treatment regimen, and then how ocular surface friendly is their treatment regimen. So I really do try as much as possible to consolidate drops. I'm a huge fan of the timolol dorzolamide combination. I'm a big fan of the timolol brimonidine combination. Intermittently, those have been kind of harder to get. And of course, if you have one of those allergies, then, then it's not quite as good. I also do really like the brimonidine brinzolamide combination. That has typically been less used for me because I think those two drugs just in combination are a little bit less impactful together, and it's harder for patients to get. It doesn't have as good insurance coverage. So both the dorzolamide timolol and the brimonidine timolol are available generically now, so it's not quite as much of a cost burden on the patients. The other one I really like is the latanoprost and the rokinase combination drop, because that's two really powerful medications just dosed one drop once a day, and that makes a big difference for a lot of patients.
Absolutely. And, it would take an entire podcast episode to dissect how difficult it can be to get patients the medications that they need, and kind of like arguing back and forth with insurance companies, and the glaucoma drops are somewhere that we deal with this a lot. So it's nice to be able to offer that to our patients. Okay, so one kind of closing question for special patients. So, for example, a pregnant patient, how would you manage a pregnant patient that has glaucoma or that needs to use glaucoma drops?
I check in with my pregnant patients pretty frequently. We know that pregnancy itself can just cause changes everywhere, and particularly to eye pressure. So, when a patient is pregnant, we'll check them every 4 to 6 weeks throughout their pregnancy. Part of that is just to make sure we're keeping an eye on their eye pressure. And then some of that is to make sure that we are um, changing their medications to what is appropriate for their stage in pregnancy. And of course, not a lot of great data, just like with all medications. We don't have a ton of really, really amazing data on this, but we do know from mechanism of action and animal studies that some are more safe than others. So in pregnancy, brimonidine is safe, and latanoprost is safe early. So brimonidine is the only one that you can really stay on throughout the entire duration of your pregnancy, but it is not safe for women who are breastfeeding. So what I typically do with brimonidine is I'll have my patients be on that. If that can be the only medication that they're on throughout their pregnancy and I can manage everything through brimonidine, that is fantastic. Then as we get into the third trimester, I warn them, hey, when is your due date? You're going to want to stop your brimonidine at least 2 weeks before your due date arrives if you're planning to breastfeed. And then we'll start to transition to something that is a little bit more safe for them once they've made the transition from being pregnant to breastfeeding. Timolol is another one that is actually pretty safe. It's a class C technically, but we give it to pregnant mothers quite frequently orally, and we also give it to babies. So that is one that can be added as well. Latanoprost is safe to use early in pregnancy, but prostaglandin analogs can cause early uterine contractions. Just whenever you're thinking about pregnancy and glaucoma drops, remember that little tidbit. And then carbonic anhydrase inhibitors, there's been linked in animal studies to early genetic defects, and so that's something we try and avoid in our pregnant patients.
I feel like the first time I heard of prostaglandin analogs was during an OB rotation, and then I started to see them in ophthalmology as well. So that makes sense. I just want to stress for the listeners, especially the medical students and like the early residents, why do we not give brimonidine to babies?
Central respiratory depression is the biggest risk. These patients can essentially stop breathing, and as you can imagine, that is not ideal in anybody less than 2. So never, ever, ever use brimonidine in patients 2 or younger due to the risk of apnea.
Exactly. And I think thankfully, there are very few things that we can do in ophthalmology that could harm someone's life. But that is one of the things that you absolutely need to know is never, ever,
Never, ever.
never, ever.
Never ever. I'll throw one other pearl out. I had a co-resident put a patient in the ICU because she was dosing, acute elevated IOP, was dosing timolol every 5 minutes. And with that much timolol on board, you can absolutely 100% put someone in heart block. So I usually tell patients it's impossible to overdose on your glaucoma medications except for timolol. Try and only use that one 3 times a day maximum.
Wow, that's surprising because our protocol, I mean, it was 5 minutes 3 times and then stop.
And then stop.
Yes,
Yeah.
but sometimes when the pressure wouldn't come down, you would just keep going with whatever drop comes to your hand, so that's really good to know. It's unfortunate when a patient has to suffer or someone has to go through that, but it's a good learning experience for other surgeons out there for us to know never ever do that. So that's a great little pearl. Okay, so as we think about our glaucoma patients, we think of this as a chronic condition that they're dealing with lifelong. And it requires treatment that's lifelong. And that can be challenging. It can be challenging for the patient, certainly, but also for you as their doctor. How do you help manage that expectation? How do you help patients through their treatment? Kind of like, how do you talk to them?
That is a really great question, and that's actually one of the harder conversations I think to have is when you're starting a patient on a medication and they come back and their pressure's lower and you're really excited because your treatment is working, and then the patient's like, "Well, how long am I going to have to be on this?" And you realize like, "Oh, I have not done a good enough job of explaining that this is a chronic disease and it's going to require chronic treatment and you will have glaucoma for the rest of your life. And so you will need treatment for your glaucoma for the rest of your life." I will oftentimes kind of draw an analogy between glaucoma and any other chronic disease they might have, like blood pressure, diabetes. So, like, hey, you also have diabetes, and so you have to keep taking your metformin, and you might reach a point where even you don't need your metformin anymore. Say you've done diet control and some other interventions that have also helped with your blood sugar, but you'll always have diabetes, so you'll always have to come back and have your blood sugar checked, and so you're always going to have to come back and have your eye pressure checked. And right now the way we're managing your eye pressure is drops. So for right now, this is something you're going to have to use all day every day. And I do kind of tell them there might be other options out there. This is when I'll talk about SLT. I can talk about cataract surgery and MIGS and other interventional options that exist, especially for patients who really don't tolerate their drops or really live a lifestyle that makes drop compliance difficult. But I essentially reinforce with them like, you and glaucoma are married now and you can't get a divorce. This glaucoma is with you forever. And so we have to just embrace it and embrace the treatment that comes along with it. And for right now, that means drops, and it means using your drops consistently. And I'll often talk about one of the things we know with glaucoma is that it's not just IOP elevation that is a risk for progression, it's pressure swings that increase the risk for progression. So I tell them it's not just using your drops, it's using your drops consistently that is going to protect you from losing your vision.
Dr. Simpson, this was such a great episode. So much important information there for all of the trainees out there, and even for some of us to kind of think back on when we're not thinking about glaucoma drops all the time. Thank you so much for joining us on this episode of the Pupil Pod.
It was my pleasure. Thank you so much for having me.
And thank you to those tuning in. See you next time on the Pupil Pod.